1 o'clock. Good afternoon, everybody, and welcome to the inaugural INNEG webinar. Little bit of housekeeping just before we begin. We have a Q&A function above where you are welcome to send any questions in for Dr. Shangaris to consider at the end of the event. We'll try to read through a few of them. Obviously, if there are any questions which we don't manage to cover, Dr. Shangaris can respond to you and we'll get an answer to you after the event. Secondly, this session is being recorded, so the recording will be made available to you all in the next couple of days. So quickly to introduce, I'm Leo. I'm a director here at INNEG. In 30 seconds, for those who haven't worked with us, we support solicitors who specialise in clinical negligence and serious injury. There are some of you who likely struggle with sourcing high-quality medical experts, particularly for complex matters. INNEG have relationships with over 13,000 medical experts across all fields, and our team can support you on an occasional or a more regular basis. Or that might not be a problem for you, but you find it exasperating spending time and hours on unrecoverable admin tasks, such as chasing experts and their secretaries for reports, organising conference calls, and you've been dreaming of a better solution. Or lastly, neither of those 2 points might be challenges to you, but you find it frustrating and time-consuming organising diagnostic and treatments for your clients. That aside, I would just also like to highlight our fantastic blog that's been going for over 3 years now, available for free on our website. It has dozens of medico-legal articles, and check it out. It's a valuable resource. Moving on to today, given that birth injury is a major part of every clinical negligence solicitor's practice, as well as ours here at INNEG, we felt that Dr. Shangaris was the best person to present our first webinar, given his experience and knowledge in this area. So without further ado, I would like to introduce you to Dr. Shangaris, and please take it away.
Thank you very much, Leo. My name is Panicos Shangaris. I am a clinical senior lecturer and a consultant in maternal and fetal medicine and obstetrics at King's College Hospital and King's College London. I graduated from the Royal College of Surgeons in Ireland in 2005, and I did a master's degree at UCL on prenatal genetics and fetal medicine, and I also did a PhD in fetal medicine. I do have quite a lot of my time spent in academia. I do 50% research, and I have a research group at King's College Hospital and King's College London. And I also did a subspecialty in maternal and fetal medicine at King's College and Guy's and St. Thomas's Hospitals. And I completed that about a year ago. And my current role in King's College Hospital is I look after complex pregnancies. I scan pregnant women with fetuses affected by congenital disorders. And I also counsel women who might want to interrupt the pregnancy. I also have a media editor role in the Reproductive Sciences Journal. And I started my interest in the medical legal practice about 2.5 years ago, when I organized a study day with the Royal Society of Medicine on the litigations in obstetrics and informed consent, and I had the pleasure of having one of the speakers was Ms. Nadine Montgomery, and also James Badenoch, who was her barrister for her case, and that basically made me increase my interest in medical legal practice. This is the specialty areas I am interested in, basically high-risk pregnancy, maternal medicine, and also fetal medicine. I just put this slide because I wanted to everybody to understand how the pregnancy works if someone is pregnant in the United Kingdom. And so the duration of the pregnancy, when we say this is a term pregnancy and we say that term is 40 weeks, is actually not, because what we say term is between 37 and 42 weeks. So what happens is when someone is pregnant, they miss their period at around this time, and by the 5th or 6th weeks of gestation, they do a pregnancy test, and they call their GP or their local unit where they can basically say, I'm pregnant, I would like to register the pregnancy. So at that point, the hospital will give them an appointment where they will go and do the booking visit. And at that point, they see the midwife, and the midwife asks them a lot of questions, and they do blood tests where they can identify any risks for the pregnancy. And this is done at around 8 to 9 weeks. During that time, the pregnancy is booked, and the midwife who books the pregnancy arranges for that pregnant individual to go and have the blood test, the scans, and the appointments, just the routine appointments during the pregnancy. Routine appointments during the pregnancy are about 10 to 11. If you are found to be high risk, then the appointments are more. And depending on whom you see, you might have an appointment every week or every few days, depending on how risk is the pregnancy and what exactly is the condition which makes a pregnancy high risk. So I will not go into very details into that, but what happens in the UK, you get usually 2 scans. One scan is at 11 to 13 weeks, which is about here. And during that scan, your sonographer will check how many babies are inside. If it's one or two babies, the length of the baby, the thickness at the back of the baby's neck, and also if the baby looks normal, so if the baby has a head, hands, and feet. Also, at that appointment, we do a blood test, and the blood test will be used for the combined screening test, which will give a risk for the baby, for the fetus, to have any of the 3 trisomies, trisomy 13, 18, and 21. And then after that appointment, depending on which hospital you are, you might get a result back within half an hour, or the following day. And they give you an appointment, they give you a risk which can be high risk for Down syndrome or not. Or also some units, they give you a risk if you are, if they give you a risk for developing preeclampsia. Then you do your 20-week scan, which is around here. And the purpose of that scan is to identify any congenital abnormalities. So we usually look at the brain, the heart, the kidneys, the genitalia, the gastrointestinal tract, the hands, feet, if they look normal, and also we measure most of these structures, and we put them in a standardized charts, and we say the baby looks normal and there is no congenital abnormality or any soft markers of chromosomal or genetic problems. And of course, if you are found to be high risk for any blood disorders, you are counseled and you are offered further tests to identify if the fetus is affected or not, which is an amniocentesis or CVS. But this is basically something which you can discuss on another day. So this is how the pregnancy works in the UK. In other countries, the appointments are more regular or more infrequent. But this is evidence-based approach. And usually if the pregnancy is defined as low risk, the pregnant individual only sees the midwife, and the doctor is only there if there is an issue during the pregnancy. So today we are going to talk about consent and what the purpose of consent in an obstetric emergency. So this is taken from the General Medical Council guidance. And what the General Medical Council says is that the patients have the right to be involved in any procedures which involves their body. This has to be discussed with the treating clinician. They have to receive clear information, and they need to be able to have capacity to make decisions. And the patients who do not have capacity, then you need to take into account, and then the discussion is who will give the consent on their behalf. And for the doctors, the important thing is that the doctor needs to give enough time for the patient to make that decision. Everything which is discussed needs to be written in the medical records, otherwise it hasn't happened. And also, if there is any disagreement between the patient and the treating clinician, then this also needs to go into the notes. It is important that the consent is informed, and the decision making needs to be discussed with the patient, and this comes after a few cases which I'm sure you know better than me. For example, the case of Nadine Montgomery in 2015, where basically shifted everything from the doctor knows best to a patient-centered decision making, and the importance of the fact that the doctors need to give all the risks and reasonable alternatives to the patient and allow the patient to think about it and make their decision. In addition to that, the latest ruling basically showed that the doctors must present all reasonable treatment options, but not only just the preferred ones, and patients have the final decisions. So timing of consent, when is the best time to consent the patient, give the risks, and how much time you should give to the patient to make a decision. So I guess this depends on the case. For example, in obstetrics and gynecology, if you are about to perform a hysterectomy and you are seeing a patient in your outpatient office, then you discuss the risks of the hysterectomy like a few weeks before the actual procedure, and you give out the risk, you give information, you can actually direct the patient to internet sources so they can actually see what type of operation is that, the risks, and you allow the patient time to think about it. And then you need to meet the patient again to discuss what they thought, what their concerns are, and then you sign the consent together. And then the consent is also confirmed when the patient comes for the treatment on the day of the procedure. You go again through with the patient the risks, make sure that the patient understood and they are still happy to go ahead. Now, if this is happening in an emergency, which is what we are discussing today, this is probably a bit different, because you don't really have time in some cases to allow the patient to think about it for a few days. The consent, the responsibility for consent rests with the treating clinician, and this basically needs to be documented in the notes. And this is what I just mentioned. Everything needs to be documented in the notes, together with all the risks which were presented to the patient for the patient to make an informed consent. In an emergency situation, sometimes we do consent patients by taking an oral consent, but this needs to be documented in the notes that the patient has given oral consent to perform a procedure. So usually legal issues arise when the patient does not receive all the risks, and they go under a procedure which ends up badly, and then the patient says, actually, I wasn't informed that a forceps delivery has a 15% risk of a third-degree tear, for example, and if I knew about that, I would have opted for a cesarean section. So everything needs to be documented in this situation so that the patient knows and understands the risks for any procedure they are going to have. So as discussed, this is a time-sensitive decisions. We'll go through a couple of cases which time is important. And in obstetrics, we have high-risk situations where we actually don't have time, because if we wait for the patient to discuss with their parents or their partner about an emergency cesarean section for a fetal bradycardia, when we have actually a few minutes to deliver the baby, then that's not possible, and the consent there is actually might not be informed. So effective communication with the patients. We always try to simplify things for the patient. We try to avoid any medical words which which are confusing for the patients. And also, if we have time, sometimes we do use visual aids. We draw on a piece of paper what we are going to do so that the patient understands fully how a procedure is going to be done and what the risks are. And I do that usually when we are explaining about the third-degree tear and what happens when we repair it. So in obstetrics, we do have a multidisciplinary approach. It's not only the obstetricians. The obstetricians actually they are on the labor ward to help. The whole show is run by the midwives who care for the patients from the beginning to the end of the pregnancy and the delivery of the baby. They check the baby after the baby is born. So the obstetricians actually are there just to help in an emergency. We have fetal medicine specialists like myself, where we care for patients with carrying a fetus with an abnormality or a fetus who is at risk of dying in the womb. We have obstetric physicians who are actually medical doctors specialized in obstetric medicine, and they see patients with conditions in pregnancy. For example, rheumatoid arthritis, pregnant women with rheumatoid arthritis, or lupus, systemic lupus erythematosus, individuals who have been affected by gestational diabetes or severe preeclampsia. Then we have the neonatologists who help when the baby is delivered and needs support to breathe, or the baby has a congenital abnormality such as congenital diaphragmatic hernia, for example, or spina bifida, and the baby will need care after delivery. And they do see the pregnant individuals before delivery so that they explain how the delivery will be conducted and what steps will be taken to make sure that the newborn baby survives, and if the baby needs to be admitted, for example, in the neonatal unit. The anesthetist is always, they are always on the labor ward, and they advise for any pain relief. They give epidurals, or in some cases, they might need patient control analgesia, for example, in cases where the baby died in utero, and we offer the so-called PCA for pain then the anesthetist is there to support and provide this pain relief. Maternity support workers are also part of the multidisciplinary team, and they help with taking blood pressure, helping with medications, signing off patients, or changing the catheter if needed, and so on. The radiologists, we very rarely need them, but sometimes after cesarean section, if we are suspect for any bowel injury, we need the radiologist to approve a CT scan to confirm if an injury basically is if an injury happened. Bereavement midwives are very important for the support of the patients who lost their fetuses in utero, and they do follow families up after delivery, and they give support and during the in-stay on the labor ward until the fetus is passed, and also postnatally. And of course, the pharmacists are always there to double check that the medications we prescribe and provide are correct. And if there is any better alternative, they always call us and tell us this is probably a better option. So try to change that medication, or this patient was on a different medication antenatally. Why have you changed it? And this can make a difference, because some patients don't respond well if we change the medication they are on, for example, for blood pressure control. So we'll go through three cases which basically are emergencies we see on the labor ward quite frequently, and I will discuss the importance of consent. So the first case is a 28-year-old woman. She books low risk. She's 38 weeks pregnant, and this is her first pregnancy. And the patient presented to the emergency department. She was sent upstairs to the labor ward, and she had spontaneous rupture of membrane. The midwife, basically, who saw her, does a vaginal examination, and she identifies that there is a cord coming out from her vagina. So what happens in that situation? Then the midwife will need to call for help. Then the patient needs to be placed in a knee chest position to relieve pressure. I will show some pictures of what this means, so that the cord is not pressed, or the head is not pressed against the cord, and so you can buy time for the women to be moved to theater. Then the obstetrics team comes over, and they identify that this lady is not fully dilated, and she will need to have an emergency cesarean section. So this lady is knee chest position, and she has no analgesia on board, and you have a few minutes to take this woman to theater, put her under general anesthetic and or a spinal if the anesthetic team is happy that they can give a spinal faster than a general anesthetic. And you have a couple of minutes to go through the risks and benefits of a cesarean section in a case where actually you have no other option, and if you don't do anything, the baby will die in utero. And this lady actually now thinks that she needs more time, and she needs to discuss with her family if this is the right thing to do. Now, the issues with the consent in this case is it really informed? Because you don't have a lot of time. You need to make sure that the patient is fully informed about the risks of the cord prolapse, and the risk that if she doesn't do anything, that her baby will die, and the need for an urgent delivery. Make sure that this lady has the capacity to receive all this information. And of course, at that point, now the woman is very anxious, and how much information can she receive at this point? So potential litigations in this case is if there is a delay in treatment. In this case, we need to do a category 1 emergency cesarean section. I will go through the categories of the emergency cesarean after the next case. So there is a delay in court in taking this lady to theater. For example, then the baby dies, then they can sue the hospital that there wasn't a fast enough response to deliver the baby within 20 or 30 minutes. The other risk of litigation is the obstetric team performs an emergency cesarean section, delivers the baby, but actually they injure the bowel and they cut the ureter, and which is one of the risks. But actually, because of the urgency of the situation, these risks were not explained to the lady, and she said that she never knew about that. She wouldn't have accepted to have a cesarean section. If you don't document that you have explained and you discussed all the risks with the woman, then there is an issue, and this can go to court. So it's very important, because in a court prolapse situation, it's very difficult to do all this, to explain to the pregnant patient who has a few minutes, where you have a few minutes to deliver her baby, that there is a list of 30 potential injuries that she can sustain if she goes for a cesarean section, but actually the risks is 1 in 500. But you have to tell her, because she needs to understand and sign an informed consent. The other thing is there is an consent from the anesthetic point of view, because giving a spinal or general anesthetic, there are risks as well. So actually the consent is not only from the obstetric team, is also needs to be given and explained by the anesthetic team as well. So in this case, they were able to communicate effectively. They did an emergency cesarean section under a general anesthetic, and the baby was born within 25 minutes alive with good EPGAR scores. So what is a cord prolapse actually, and what are the risks of cord prolapse? So this is like an algorithm, or what we should do when there is a cord prolapse. In this video here, taken from this paper, you can see membranes which are bulging into the vagina. This is the vagina, and basically the cord is prolapsing into these membranes. So you can see the cord now. You see this part here, it's a cord. So as soon as the membranes go, this cord will come out of the vagina, and you'll have an obstetric emergency. It's very rare to get this video actually, because if you have this picture, usually you might need to go to theater and do an emergency cesarean section. But this group in Hong Kong, they were able to do it. So this is what we said about examination. So when someone comes in labor, they have to be examined and to identify if they are dilated. And that's when the midwife identifies there is a cord coming out. And there are a few maneuvers we can do to basically prevent this cord to be compressed by the fetal head. So one, we can put a urinary catheter and fill in so that it pushes the baby's head up, so it relieves the pressure. This is the knee to chest. This is what I described in the case. So can you imagine if you try to explain to someone in this position and try to take an informed consent? And I'm not going to discuss asking this person to sign, because it will be a bit difficult to do that. Then this is what is called the Trendelenburg position. You can move the bed like that, so that you can use gravity to assist you relieving the pressure. And And the other thing you can do is put this wedge where you have it in the anesthetic theater to again use gravity to relieve the pressure from the cord. So these are the classifications of the emergency cesarean section. We have category 1, 2, 3, and 4. Category 1 is usually when we need to deliver the baby like now, and the recommendation is to deliver the baby within 30 minutes. And this happens if there is an abruption, cord prolapse, fetal hypoxia, or persistent fetal tachycardia. Category 2 is when, for example, we are suspecting that there is sepsis, but actually we cannot. We have time to give antibiotics and prepare the woman and make sure that she gives informed consent. And we do have about 75 minutes to do that. So it's a bit of a more in a more controlled situation. Category 3 is in a semi-elective environment, is when we are starting an induction of labor and the induction doesn't work and the patient does not respond to the medication. There is no dilatation. Both the baby and mother are healthy and happy, so you can do it when the elective theater is ready. And a category 4 is a scheduled operation when you can do it. We can just schedule it a few weeks before, and this is done the same manner as any type of elective procedures. So the second case which I have is an emergency cesarean section for fetal bradycardia. This is a 32-year-old lady, 39 weeks pregnant, on her second pregnancy. The patient was admitted for induction of labor and for preeclampsia, let's say. And during labor, when she was 4 centimeters dilated, the fetal heart rate dropped down to 60 beats per minute. And this is now for more than 3 minutes. So the immediate action is to try and take some conservative measures. For example, we change the position. If this lady was on any oxytocin, we stop the oxytocin drip and make sure that if that was after an epidural top-up, we wait because that sometimes happens and usually picks up. We do an examination to make sure that there is no cord prolapse. And also sometimes when the pregnant individual is fully dilated, when the pregnant individual reaches fully dilatation, then you can get some deceleration. And we can identify that by a vaginal examination. Now, the obstetrics team usually is called. We have an emergency buzzer in the room, and the midwife who attends the pregnant lady, they pull the emergency buzzer. And usually everyone who's on the labor ward floor go into that room and try to identify what's happening and resuscitate the lady by doing the conservative measures. And if it doesn't work within 6 to 9 minutes, then we need to prepare this lady to go to theater for an emergency cesarean section. So again, it's a similar situation as the cord prolapse. The only difference, I guess, this lady is not in the knee to chest position, so you can actually speak to her and she can potentially sign a consent form, especially if you go there immediately, explain to her that we might need to start moving in 3 minutes if the bradycardia persists, and you have slightly more time to explain the risks to this lady and take a bit more of an informed consent rather compared to the cord prolapse case. Make sure that the patient understands the severity of the situation. She's only 4 centimeters, for example. We cannot deliver the baby vaginally if she's still 4 centimeters. So we need to start moving the patient to theater, and we need to document. Usually in these situations, we have someone allocated to scribe and write everything that is happening in the room. And this person is usually either the maternity support worker or one of the junior or student midwives who are on the floor, and or the medical students. So actually, if there is an emergency situation, usually we do have a scriber, and this is a bit more. We have more documentation than if we have only one person speaking to the patient and there is no team around them. And the potential litigations is if we don't go to theater early enough and the patient doesn't make it. If we don't explain the emergency to the lady, and the lady or the lady starts saying that she needs to discuss this with her family who are in another country, and they want to have a FaceTime call, and we do have these patients who in an emergency they want to speak to their family, and of course these patients are giving a consent under pressure. And later, a few of them think that feel that the consent was not what they wanted to do because they were under pressure, so they weren't giving an appropriate consent. So the main situation in this, the main issue in this situation is that this is an emergency. The patient needs to give a consent. And we need to move to theater as soon as possible, especially if the fetal heart rate is not recovering after 9 minutes. And documentation is important. And the reasons why moving to theater is important and why an emergency cesarean section is important needs to be communicated to the patient, and this needs to be documented in the notes. So this is from taken from guideline, but this is what we use in most of the hospitals. And this is what happens. So if we have bradycardia for 3 minutes in the room, the midwife who looks after the patient pulls the emergency buzzer. All the team goes there, and we try the conservative management initially. Usually more than 90%, 95% of the bradycardias recover after 6 to 9 minutes. If they don't recover, then we start moving to theater. And the delivery needs to be done via an emergency cesarean section, category 1, and usually this needs to be done within half an hour. Causes, they can be, first of all, it can be unknown. Sometimes we don't know why this happens. Sometimes it's due to uterine hyperstimulation, is when we give too much hormone drip, for example, and we need to give something to stop the contractions, such as terpudalin or salbutamol. Sometimes this is due to placenta abruption. This is when the placenta comes off the uterine wall, and this is an emergency, and this needs an emergency cesarean section. Previous cesarean section, which with a scar rupturing, and actually when you do a cesarean section in this situation, the baby is actually in the abdomen and not inside the womb. And also we need to think of maternal or fetal causes, for example, meconium, when the baby passes poo inside, if the baby is small, if there is an underlying infection, and also if the baby is preterm, or if the baby is postterm, 42 weeks, for example, refusing induction of labor because they want to start the labor process by themselves, and then sometimes you can have placenta abruption in these cases. And this is what I just mentioned, the causes of fetal bradycardia and how we can identify them. So I do have another case. I'm sure I have time to do that. So this is actually a true case. This is a lady who is 21-year-old. This is her first pregnancy. Initially, she was low risk, natural conception, and she suspected to have preterm rupture of membrane, pre-labor preterm rupture of membrane. This is that when the membranes rupture, and then actually she doesn't go into labor within 24 hours. And usually what happens is if someone comes with rupture of membranes at term, we advise them to go home and to come back 24 hours later to start the induction of labor to prevent any infection. And this is because we have data. If you leave the membranes rupture for more than 24 hours, there is a high risk of infection and chorioamnionitis. So this lady does come back. Unfortunately, because of a delay in induction of labor due to staff shortages and also hospital beds, the induction of labor doesn't start within 24 hours, and it does start 48 hours later. So in this case, what happened is she started developing sepsis, and there was fetal distress and needing for her to go into theater and having a forceps delivery. And during the forceps delivery, she was quite exhausted. And she was actually, someone was holding her hand to sign the consent form. She couldn't remember any risks, and even those were explained to her. Actually, she wasn't in a situation where she could absorb any of the information that clinical team was providing to her. And her partner was holding her hand to sign the consent form. So the question in this case is, was there an informed consent? Because for me, this is probably not a consent form. In addition to that, after the forceps delivery, there was a retained placenta which was not initially identified. And also she experienced a third-degree tear, which was one of the risks of the forceps delivery, but she couldn't actually remember that this happened. This was explained to her, so she's questioning about the risks which were not explained to her before this procedure was done. And what the other information this lady shared with me was that during the repair, the clinical team was arguing between them because they didn't have time to have lunch, and someone has to come and take over, and they didn't. So there was actually an argument between the clinical team when she was lying in bed, and the obstetrician was trying to repair her third-degree tear. She developed post-traumatic stress disorder. She had to have private counseling sessions. And also, she, for the first months after delivery, she didn't want to care for the baby. The partner had to care for the baby due to the post-traumatic stress disorder. So there are questions in this case that there were concerns about the process of consent, and also the delay in inducing the labor. There was also some mistake in the medication they gave her during her inpatient stay, which was not communicated well with the teams about the dosage of the opioid she received. And also the fact that actually she was asked to sign a consent form, and someone was holding her hand to sign the consent form and couldn't remember what she signed for. The hospital actually in this case addressed and wrote an apologetic letter saying that we do know that prudentially you stayed in labor with prolonged rupture of membranes of more than 48 hours, and this could have led to the sepsis and forceps delivery afterwards, which ended up as a third-degree tear. And they haven't actually apologized officially about the delay. In addition to that, because of the repair, she asked for a private room. and there wasn't one available, but there was one available privately. So they asked her to go to that room, and they basically billed her afterwards for the use of that room. And a few hours later, they said, we actually need the room, so you need to come out. So they took her out. So it was quite of a traumatic experience this lady had in this hospital. Of course, if there are staffing issues, if there are no beds, the question is what the clinical team can do to prevent that from happening. If there are no staff on the floor, then there is no staff on the floor. You cannot really do anything about it. So the question is there anything which the hospital can do to employ more staff and prevent this from happening? Is there a way of making sure that the clinical team maybe discuss all the risks before forceps, so at the beginning of the induction of labor, which is sometimes what we do. We explain that induction of labor means that you might end up having an instrumental delivery, which has the risk of perineal damage, and these are the risks. These are the percentages, and these are the people. How many people in our unit who end up having an induction of labor have forceps delivery, and what is the national percentage? So I think this is the end of the presentation, and the important thing is that you need to make sure that the patients get an informed consent. And informed consent in 2024 is probably different than the informed consent in 2009, after all the cases which went to court and successfully went to court. Any questions? I can stop sharing probably.
Hi. So thank you very much, Dr. Shangaris, for the presentation. I found that very interesting, particularly those case studies, and I hope everyone else found it interesting as well. A quick Q&A session now. No one's put any messages. Oh, someone's asked if these slides will be available anywhere after the presentation. So with your permission, Dr. Shangaris, will make them available as well to anyone who might want them.
Not a problem.
And obviously, if people have questions about specific cases which they're working on and would like to speak with Dr. Shangaris separately after the event, of course, we will make his details available for you all following again. And just lastly, a couple of questions, if I can ask from my side in relation to your medico-legal practice. First of all, are you able to clarify again the areas which you specialise in relation to medico-legal work? So obviously everyone on here can know what they can approach you for.
Yeah, I can look at cases where similar to the cases I presented. In addition to that, I can look at fetal medicine cases. So it's obstetric, maternal fetal medicine, high-risk fetal medicine, complex cases, congenital abnormalities, intrapartum care, and so on. So look at all these cases.
Wonderful. No, thank you. And what's your current availability to report?
I think at the moment is about 6 weeks, 6 to 8 weeks, probably.
Perfect. Okay, brilliant. Well, that gives everyone an insight. Again, thank you very much.
And I can assist with TTTS, yes, which is fetal cases, yeah. There's a question.
Oh, here, we have a question here. Yes, sorry. I don't know if you can see it as well, Dr. Shangaris, but is there a solution with regards to informed consent issues by providing more information to women during pregnancy?
Yes, I think this is important, and during antenatal clinic or when any pregnant individual sees the midwife, it's important to discuss that things can go wrong, and these are the risks which can be. These are the risks which are associated with anything which can go wrong. For example, risk of a cesarean section can be very easily discussed because at the moment in tertiary units, their cesarean section rate is about 35%. So 1 in 3 pregnant individuals end up having a cesarean section. So discussing the risk of a cesarean section, which will probably take 10 minutes and documented. And then when someone comes with a cord prolapse, it would be much easier to discuss the risks because they have already been discussed. And the pregnant individual will tell you, oh, I have discussed the risk and I know I'm happy to sign the form because this has been discussed before and I know the risks, rather than trying to explain the risks in an emergency situation where you have a few minutes to deliver the baby.
Wonderful. And I've got another one here. Is a 4th degree perineal tear a recognized risk of forceps delivery, or is it negligence?
It is a recognized risk. It's very rare, but it does happen. But a 3rd and 4th degree tear is part of the risks which comes with forceps. And this is important because some women might say, I don't want 15% risk of having an anal sphincter injury. I want to have a cesarean section.
Good, thank you. And here, last question currently. Hold on, there's a couple more, but last question here. In cases where internal trust policies are different to NICE guidelines, what usually takes precedence?
This is a very good question, but usually the internal hospital policies do follow NICE guidelines. So I think we need to take that case by case because it depends what type of question is this. Usually the hospital guidelines are based on the NICE guidelines, but if the clinicians follow the hospital guidelines, then it's a bit difficult to say that they are negligent if they are actually following the unit's guidelines.
Wonderful. And a couple more have popped up. So you mentioned the importance of medical records. If it is not written down, it didn't happen. How realistic is it to record everything at the coalface? Is there sufficient time? Is it a drain on your resources? And it is easy for us lawyers to say it's important, but this Georgina here would be interested to hear how realistic it is for clinicians and or midwives to record everything.
So the best people to record everything are the midwives. I have to admit that, but it is difficult to record everything in an emergency situation, and that's why when we do multidisciplinary skills training where we practice emergencies like cord prolapse, and we always have a dedicated scriber where they write down exactly what's happening inside the room. It's difficult, but we get training to do it. We get the appropriate training to actually do it. And all hospitals do have a mandatory training, which is called PROMPT. And all clinicians, including midwives, and everyone who is on the labor ward needs to go through the mandatory training. Which includes working together as a team in an emergency, having a scriber, and dedicating tasks so that the patient gets the best care.
Wonderful. And Helen here is asking, is it acceptable to proceed with an instrumental delivery without an episiotomy if there is significant risk to life? Would there need to be information given about the risk?
So usually the advice is if you are doing an instrumental delivery, you should try and do an episiotomy because of the risk of perineal injury. And it does take a couple of seconds to actually do an episiotomy. But it depends on the case. But the advice is if you
so you can look at that.
Yeah.
So if they wanted to send you some more detail on that particular matter, you would be happy to look at that.
Yeah.
No problem. And just lastly here from Jane, would you need to speak to the claimant prior to preparing a breach of duty report if it's in relation to discuss the consent issue? Do you want to speak to the claimant to discuss consent?
So a few cases I've done, I've done cases without speaking to the claimant, and I've done cases without. It basically gives a better picture if I speak to the claimant and I get the full picture, because what's written in the notes sometimes is completely different from what the claimant says, and it's much. It makes the handling the case easier.
No problem. So you would recommend,
yes,
on most cases, a quick conversation with the claimant in relation to the breach of duty issue if consent was the issue.
In any case, actually, not only consent, in any case, because if a claimant is asking, is basically saying that there was negligence against the hospital because of an issue, then it's better if you speak to the claimant and clarify exactly what they mean. Especially if they haven't yet had an investigation in the local hospital and there is no letter which outlines the investigation of the hospital, speaking to a claimant is very, very helpful.
Wonderful. Well, I think that rounds it up, everyone's questions. So again, thank you very much, Dr. Shangaris. And just to say, what we will do is we'll make this recording, the presentation, and Dr. Shangaris's direct details available to you all if you've got any further questions or if you want a copy of his CV. We'll also be sending out a short feedback form for you to fill in. Just take a couple of minutes, and we'd really appreciate if everyone could fill it in. So again, lastly, thank you everyone for attending. We will be launching our next webinar in the very near future, so watch this space. And again, lastly, thank you very much, Dr. Shangaris. Really appreciate your time today.
Thank you for inviting me.
Take care.
Thank you. Bye.